This is a design and innovation project organised by the Design SIG Special Interest Group and the Health KTN Knowledge Transfer Network, and my name is Rachel Jones. We began looking at innovation in the NHS. The NHS is the UK major health provider, and it's actually the 5th largest employee in the world, employing more than 9 million people. The cost of running the NHS is huge, and people are getting older and there's a rise in chronic disease, so it's only going to get more expensive. So how can we build innovation within the NHS that is going to add value but not cost? The way we looked at this was to adopt what's already part of the NHS, the patient pathways. At the moment, they map the journey through an illness from the day you present at a GP surgery right through to final care, perhaps in the community. They tend to be used as a management tool, and what we wanted to explore was whether they could be used to help innovators understand the health outcome of their particular innovation. We designed a process which comprised of 5 stages. The 2 most interesting are probably the future scenarios workshops, where we used what we called what-if scenarios, where we exhibited at various health innovation exhibitions. We took it to one-to-one conversations and also into small group sessions to find out what the future could be around a particular pathway that we chose, which was osteoarthritis. Even though we chose osteoarthritis as a sample, the plan was to extend it to other disease areas, so we always had that in mind. The last area of that process was really a sandbox session with multidisciplinary, different consultants involved, as well as innovators. And we, in a 3-hour session, decided to look at 2 particular areas. One about repair of the structure, the bone structure, and the second around pain management. At the moment, the pathway is such that you have to manage the pain and manage the symptoms through painkillers or analgesics until it is repaired with a hip replacement, and then, which would for a hip may last 10 years, and then again goes back to symptom management. In other joints like the elbow, the wrist and the ankle, it's less successful. Now, rheumatoid arthritis has completely transformed in the last 10 years. They've developed a repair mechanism, a particular set of drugs, that have pretty much eliminated rheumatoid arthritis. So what would it take to do this for osteoarthritis? We focused, as I say, on the structural side and also the analgesic or painkiller side. And we found that the pathways would be transformed as a result of interventions in these areas. Why does it matter? Well, if a lot of money and investment is put into innovation at the moment, into areas that, like diagnosis. Now, once it's diagnosed, which can be simply done through an X-ray, why spend more diagnosing it further when nothing can be done? And perhaps it is better to direct that money towards finding the next and the better analgesic and the next and best structural modifier for osteoarthritis. So where we began to look at how we might orient innovators towards health outcomes, what we actually began to focus on is how we could direct funding and funding opportunities towards particular areas which would make a radical difference in the patient pathway and the clinical outcome. Design played a significant role in this process. It was time-consuming and lengthy to involve clinicians who are busy saving lives in workshops. So we had to streamline our process, and we had to take on a clinical expert who spoke their language and could engage with them. But the outcome were visualizations which really anchored the workshops that we developed, and absolutely what they called holy grails, that if we could solve those, we would radically change pathways. So design went beyond the relationship with the customer and actually into embedding innovation in the process of innovation in the NHS.